Bismillahirrahmanirrahim. Assalamu alaikum, everyone who is able to join us today on May the 17th of 2025. I'm Dr. Kiran Ijaz from Atlanta, Georgia. On behalf of IMI Global Academic Council, I would like to welcome all of you to this session on the current management of hypertension with emphasis on renal denervation. We will be posting the link for certificates via chat shortly. So kindly register through that if you want a certificate after this session. I would like to request you to keep your microphones on mute during the presentation. You can unmute and ask questions during the Q&A session. Next, I would like to introduce the moderator for today's session, Dr. Arshed Quyyumi. He's the chair of IMI Global Academic Council. Welcome, Dr. Quyyumi.
Assalamu alaikum. Welcome, everyone. It's a real privilege to have you all here and particularly to introduce our speaker for the day, Dr. Syed Ali Yaseen Naqvi. Was born in Ireland. He works as an interventional cardiologist. Currently, he's at the Warith Al Anbiya University in Karbala. And he trained in Ireland, went to medical school there, and then completed his residency in internal medicine and interventional cardiology and cardiology in Rochester. Actually, his training was in University of Pennsylvania. Then he returned back to Ireland, currently practicing at the Najaf Heart Center, and he's doing some further educational training in professional education and will be a lecturer in Ireland when he follows. But he's widely published and also is an excellent interventional cardiologist and has specialized particularly in renal nerve denervation procedure, which is now an option for management of hypertension, and he's going to talk to us about that today. Ali, thank you.
Thank you, Professor Quyyumi, for that kind introduction. Assalamu alaikum, everyone. I just wanted to thank Professor Zaidi and Sakina Naqvi for inviting me to speak today. So the topic is hypertension, and we're going to talk about what's new in 2025. In terms of disclosures, I have nothing to disclose. So I'm going to talk a little bit about the epidemiology of hypertension, touch upon the primary and secondary causes of hypertension, talk about what the management of hypertension is with an emphasis on the 2024 European Society of Cardiology guidelines, as well as the NICE guidelines from the UK, talk about how to manage resistant hypertension, and then I'm going to have two case examples relating to renal denervation cases, and then I'm going to touch upon the trial data for renal artery denervation. So, can I ask everyone to mute their mics, please? So hypertension, as we all know, is one of the main causes of global disease burden. There's over 1 billion people worldwide that are affected by hypertension, and about 1/3 of adults have hypertension. So it goes without saying that it's an important condition, and I think in the years to come, this is only going to increase as the rates of obesity continue to be on the rise. Now, we know that hypertension is a risk factor for cardiovascular death. Studies have shown that nighttime blood pressure, what your blood pressure is while you're sleeping, is that it correlates the most with cardiovascular 5-year risk of cardiovascular death. And clinic blood pressure, in fact, is not very good at predicting cardiovascular outcomes. And the reason for that is obviously when you come to see a doctor in the clinic, your blood pressure will be higher, and this is known as white coat hypertension. So some of those get snuck into the data, but in general, the best blood pressure is nighttime, and then it's followed by ambulatory 24-hour blood pressure monitoring. So when I speak to my patients and I tell them about procedures such as renal denervation once they've failed medical therapy, I tell them about the relative risk reduction of their systolic blood pressure in the office and how much risk reduction they can get for major cardiovascular death by just a 10 millimeter drop. What I tell them is around a 20% relative risk reduction for a 10 millimeter drop in their systolic blood pressure. Now, it's important to note that this is not absolute risk, this is relative risk. Now, what's the main issue with hypertension? I think the main issue is that we have about 50% of people that are uncontrolled. So amongst those 50%, a subset of those, which is about 15%, are termed resistant hypertension. Now, resistant hypertension are patients that are on, the most standard definition is they're on 3 medications, antihypertensive medications, of which one is a diuretic. And despite 3 medications, they remain uncontrolled. Now, you can see in this slide from 1999 until 2018, you can see that the blood pressure control, and this is age adjusted, you can see that it's terrible, between 40 and 50% in the last 20 years or so. And despite awareness both on media, social media, visiting doctors, blood pressure control continues to be not optimal. Now, studies have shown that from the time you get your initial prescription, your adherence drops continuously. 50% of patients stop their blood pressure meds within 1 year of their diagnosis. And I think poor drug compliance is probably the number one factor of why patients have uncontrolled hypertension. And I think a subset of uncontrolled hypertension that are resistant is also related to poor drug compliance. So I think it's really important to emphasize taking medications. If the patient doesn't take it, it's obviously not going to work. They've done a study in the UK where they looked at the number of hypertensive prescription, and the more prescriptions a patient has, the higher likelihood they are not taking the medication. So again, I think adherence is probably the most important thing, or the most important thing when it comes to blood pressure management, particularly in patients that I see in my clinic that are referred for renal artery denervation. I think now there are various ways to test whether patients are taking their drugs, urine testing, or directly observing them taking their medications, which I do in my practice. Now, in terms of hypertension, we have primary hypertension, which is essential. And this is the most common type of hypertension that we see in the community. And it's about 95% of all hypertension is known as essential hypertension. Generally, most patients have a positive family history. However, not all patients have to have it. Patients that are obese may have essential hypertension just from obesity and poor lifestyle choices. But generally, essential hypertension starts between the ages of 20 and 50. If somebody has a positive family history, such as their mother or their father has hypertension, or their brother, chances are they'll get hypertension in their mid to late 20s. And then secondary hypertension, you can see, breaks down into, let me see if I can put my pointer, renal causes. So people with renal disease, such as unilateral renal artery stenosis or bilateral. Any type of kidney disease can cause it. And then there's medications such as the oral contraceptive pill, licorice, which is commonly used in sweets, and then medications, steroids, and other medications. There are mechanical causes such as coarctation of the aorta, which is a congenital problem. This type of blood pressure resolves with correction of the coarctation. And then sleep apnea. I think very, very commonly nowadays, patients come with uncontrolled hypertension, and when you take a good history, you notice that they have issues with morning headaches, snoring while sleeping, and I think those patients need to be referred for a sleep test. And then lastly, endocrine causes. So there are many endocrine causes, and it's really important when you refer somebody to renal denervation that you rule out secondary causes. You don't want to ablate their renal artery nerves if they have, for example, a Cushing syndrome or a pheochromocytoma. Obviously, these take precedence than ablating their nerves. So this study talks about the pathophysiology of hypertension, which is published by Vanderbilt University in Nashville. And this table I took from this paper. So I just wanted to highlight that hypertension is a complex condition. We don't entirely understand what mechanism drives hypertension in which individuals. So in everybody, and in my opinion, everybody has a different reason why their hypertension is driven. Some people, it's purely related to their salt intake. Some people, they have higher vascular tone. Some people have increased sympathetic output, so at the spinal cord level. And then lastly, the kidneys and how the kidneys adapt to natriuresis, how the efferent and the afferent arterioles communicate with one another. So it's not a very clear mechanism. And in order to treat blood pressure, we have to essentially hit all of these areas. We need medications that decrease sympathetic drive. We need medications like ACE inhibitors that will cause dilation of the renal arteries. And we need medications that acts on the vessels and reduce vascular tone, such as nitrites. Now, what's the big deal about having essential hypertension? But most patients are asymptomatic, and generally they're in the asymptomatic phase for many, many years. Very similar to diabetes. Most patients with diabetes have no symptoms, and then they'll suddenly have an event. And that's very similar to hypertension. So you can see in this graph, you can see that the target organs that get affected: number one, the brain; number two, the heart; and three, the kidneys. So in terms of the brain, you can have issues with stroke, you can have dementia, TIA. In terms of the heart, you get left ventricular hypertrophy, systolic and diastolic dysfunction, increased risk of arrhythmias because the left atrium dilates over time. And in terms of the kidneys, you'll get proteinuria and eventually renal failure. And you can see when the patients get to the symptomatic stage, it's not very long until they end up in end-stage disease such as heart failure or debilitating stroke or end-stage renal disease requiring dialysis. And essentially, we're trying to prevent people from getting to this stage. Now, you might have the question of how do we diagnose hypertension? So traditionally, clinic blood pressure was the mainstay diagnostic method that we used to use, where you'd visit your family doctor and get a blood pressure check. After clinic blood pressures in the last kind of 15 years, 20 years, we've encouraged home blood pressure monitoring, where patients have a blood pressure cuff at home. They sit down for 5 minutes with their legs uncrossed and check their blood pressure, preferably from the arm rather than the wrist, with their arm at the level of their heart. And more recently, kind of in the last 10 years, it's become more and more routine to check ambulatory blood pressure. And this is the gold standard, actually. Any patient that I take to the lab for renal denervation, they need to have an ambulatory blood pressure to definitely diagnose hypertension and particularly look at their nighttime blood pressure. Like I mentioned earlier in the talk, that nighttime blood pressure correlates the best with cardiovascular mortality. Now, this slide I took from the ESC 2024 guidelines on blood pressure. And you'd be glad to know that hypertension is still, the office blood pressure diagnosis is still 140/90. And that's been that way for many years now. I've included the ambulatory blood pressure. So an average ambulatory blood pressure above 130/80 is considered a diagnosis of hypertension. And then nighttime blood pressure above 120/70. So if a patient has a nighttime blood pressure above 120 systolic, they, by definition, European Society of Cardiology definition, have a diagnosis of hypertension and should in theory be treated. So I know most doctors don't treat at this level, but according to the ESC, hypertension is diagnosed at this level at nighttime. But in general, for the majority of patients, 140/90. Now, my previous work was in Hull University in the UK. At that time, I was asked to update the trust guidelines. It was last updated in 2016, so I did the update in 2022. And at that time, we didn't have the ESC guidelines, but I think it's still relevant to now. In terms of medications, the first line for me would be an ACE inhibitor or an ARB. Unless the patient is an African American, then I think chlorothalidone or a thiazide-like diuretic like hydrochlorothiazide could be used as first line. Second line would be a calcium channel blocker such as amlodipine or felodipine. Third line, a thiazide-like diuretic such as imidapamide or chlorothalidone. And lastly, spironolactone, which is a diuretic. In males, preferably better to use a eplerenone because spironolactone can give you side effects of gynecomastia. Doses that are higher than 50, you start getting more of a diuretic effect and rather than a blood pressure effect. So the doses above 100 are generally used for patients with liver failure, liver cirrhosis. But these are generally the first four medications that I would prescribe patients with hypertension. Once you get to number 4, I think it's time to start thinking about compliance. Is drug compliance an issue? And secondly, I think looking for secondary causes of hypertension. Now, once we've confirmed drug compliance, I think we need to think about resistant hypertension. And I think the most important thing to do is to do an ambulatory blood pressure monitor. Because some patients have white coat hypertension, where their blood pressure is high when they see the doctor. However, at home, their blood pressure is fine. And that can be picked up by a home monitor or an ambulatory monitor. It's important to look for postural hypotension, particularly in diabetics and patients above the age of 75. In those patients, aggressive blood pressure control is more risky than allowing their blood pressure to be on the higher side, because as we know, risk of falling in elderly is higher, and if they have a hip fracture, they have about a 30% to 50% mortality at 12 months from a hip fracture after a fall. And obviously, you need to discuss medication adherence. Once you've tried the 4 medications that we mentioned on the previous slide, I think it's time to use these extra medications like beta blockers, such as carvedilol is a good medication, or labetalol. Alpha blockers, which we use for prostate enlargement, for BPH. We use prazosin, terazosin. These are all good medications that can help blood pressure. Hydralazine. Alpha-methyl dopa is used in pregnant women, has been around for many, many years and very safe. And then nitrates, such as isosorbite mononitrate. Again, I think there gets to a limit. When you get to about 4, 5, 6 medications, you really need to check for medication adherence. I can't stress that enough. I have plenty of patients in my clinic that just don't take their medications. And I think it's important to either do urine testing if it's available in a nearby facility, or make sure that and make sure that they're taking their medications. And I think at this when you start thinking about referral to a denervation service. And also when patients are resistant, this is when I would refer them as well to an endocrinologist to rule out secondary hypertension. Endocrine causes of secondary hypertension is just pheochromocytoma, Cushing's, Conn syndrome. I think that's important as well. Now, I want to talk about Dr. Max Peet. He's a general surgeon from Michigan, and he was practicing as a general surgeon and then specialized in neurosurgery. And he was heading the department at the University of Michigan, and he's one of the pioneers of removing the nerves that are sitting alongside your aorta in your next to your vertebra. Now, he published this paper, Max Pete, in January of 1948. And the title of the paper was Hypertension and its Surgical Treatment by Bilateral Supradiaphragmatic Splanectomy. So he did about 2,000 operations. You can imagine back then in the 1920s and 30s, there wasn't much available other than bed rest for patients with high blood pressure. So I'm going to go through a case in just a second. So splanchnicectomy is removing the splanchnic nerves. There's two methods. Either you give an injection of a nerve block, or you can do surgical removal of these nerves or surgical disruption in the hope that it would treat blood pressure. So this is one case from Mr. Pete. In 1931, it was published. It was a 22-year-old female, and she had severe hypertension for 3 years. At that time, the only treatment was bed rest, so she was on bed rest for 8 months. And her blood pressure was about 280 over 190. Okay. On fundoscopic examination, she had stage 4 retinopathy. She had evidence of early papilledema, flame-shaped hemorrhages, and cotton wool exudate. So these are findings on ophthalmological examination, which we don't see a lot nowadays because blood pressure you don't really see blood pressure of 280 nowadays because we have medications. So this patient, after 3 years, she underwent aggressive abdominal surgery where they removed the splanchnic nerves on both sides. Post-operatively, her blood pressure was 110 over 90. 2 months later, she had complete resolution of her papilledema, hemorrhages, and her exudates were resolved. The patient became asymptomatic, and 13 years later, she had no complications of blood pressure, and her blood pressure remained within normal range. So if you look at her blood pressure checks, you can see here when they did the operation at 280 systolic, came down to 110 and hovered around 140 systolic. You can see her proteinuria resolved, her papilledema, hemorrhages, exudate, all these parameters resolved and stayed resolved for 13 years. So this was essentially Mr. Pete in the 1920s and 30s was essentially the reason why renal denervation came about in the 90s and 2000s as a potential treatment for resistant hypertension. Now, this is a case of mine from Ho. I've gotten her permission to use this for presentation. She's a 52-year-old female, past history of resistant hypertension. She was diagnosed at 18 years of age, and she had a positive family history. Her parents both had high blood pressure. She had a prior TIA. She has high cholesterol. She had issues with recurrent headaches. She had atypical chest pain, which resulted in a normal coronary angiogram in 2004, so about 20 years ago. And her father died at 36 while he was needing coronary artery bypass graft surgery. She came to see me and her blood pressure was 220 over 120. The electronic cuff didn't work. I had to do a manual check. Going back in her records, this is from 2015. I saw her, I think it was 2023. This is her medication history. She also had a normal CT angio. These are her medications. You can see she's on multiple agents, 4 blood pressure agents, and still uncontrolled. Now, the first thing I did was to check whether she has compliance with her medications. And then what I did was I started her on spironolactone, and I started her on, increased her dose of lisinopril. And I also decided this is the visit from 2015. So they added a 5th agent. And then in 2018, she presented to the acute medical assessment unit, and she was given a diagnosis of migraines. Now, she had symptoms of bilateral headaches, some visual disturbances, some nausea, and the doctor at the time in the A&E thought she was having a migraine. They went ahead and did a lumbar puncture. They ruled out subarachnoid hemorrhage, which I think is a bit aggressive because the CT was normal. So, anyways, she ended up getting discharged with a diagnosis of migraines, and eventually she came and she saw me in clinic, and I ordered her a 24-hour blood pressure monitor. You can see here, it says here successful readings 8%. So out of the entire 24-hour blood pressure recording, from a total of 70 attempts, only 6 of them were successful. Now the reason for this is because the blood pressure cuff, because it's an electronic cuff, it fails. It goes up to about 200, 220, and then the readings fail. And that's what happened in her. So the 24-hour monitor picked up a blood pressure of 170. However, I think her blood pressure was actually higher than that, similar to what it was during her clinic visit. Now, in 2023, when I saw her, I thought the first thing for me, which was important, was compliance. So what I did was I admitted her to our cardiology ward, and the nurses observed her taking the blood pressure medications and checking her mouth after to make sure she's not pocketing the medications. And this is to check for compliance. And I think this is important. Before you entertain renal denervation, you really need to make sure patients are taking their medications. Now, I want you to compare the CT on the left. Compare the left ventricle. Look at this area here on the right side. Compare it to the left side. Now, you can see here on the left side, which is a CTCA. There's contrast in the left ventricle. You can see that the left ventricle has become very hypertrophied compared to 10 years prior. You can see the LV was normal size with normal wall thickness, and the left ventricle on the recent CT was very thick, indicating severe left ventricular hypertrophy. Again, I did a confirmatory echo, and you can see the wall thickness. She had poor windows, but the wall thickness was above 1.4 centimeters. Her ECG showed severe left ventricular hypertrophy. Now, in 2023, in November, we obtained FDA approval for ReCore, which is an ultrasonic catheter which uses ultrasound waves to burn renal arteries. And this is the Paradise ReCore catheter. It's a 6 French system. Now, the other one that was on the market before is the Simplicity Spiral, which is a Medtronic catheter, which uses heat ablation, similar ablation that the electrophysiology folks use for AFib ablation. So these are the only two, and still the only two on the market. Sorry, this one, Simplicity, which is Medtronic, and then ReCore, which is the Paradise catheter. At the time we were involved, I was the PI of the local PI for the renal denervation Paradise study. So I enrolled her in the study. And just to talk a little bit about the ReCore device, the procedure is done via the femoral artery. We go up with a 6 French catheter, a JR4 or an IM catheter, shaped in a specific way to enter the renal arteries. The nerves, the efferent and afferent nerves of the kidneys are running in the adventitia on the outside of the artery. They're more concentrated towards the aorta, and they disperse more as the artery gets closer to the kidneys. Now, the efferent and afferent nerves have different responsibilities. The afferent, for example, increases sympathetic outflow. The efferent is involved in increasing renin release and decreasing renal blood flow. So the thought behind renal denervation is to disrupt these nerves by either heat ablation or ultrasonic ablation and cause improvement in hypertension. Now, the ideal renal denervation catheter should ideally should be able to give you circumferential
Oh, you're frozen.
Yeah,
Hello, Dr.
hopefully,
Naqvi. Can't hear you. Internet,
hopefully he'll call back in again.
internet issue.
There you are.
Apologize. Can you hear me? I'm back.
Okay.
Okay, so I'll continue. So the ideal catheter needs circumferential burning, and we want to minimize damage to the vessel wall and
Ali, you'll
minimize.
have to show the slides again because they went off as well.
Oh, okay.
Good,
Yep. Let me do that. Okay, so just to talk about the Radiance trial, this is for RECOR, which is the ultrasound-based catheter. You can see in mild to moderate hypertensive patients, comparing it to sham. So a sham procedure is where the patient comes to the hospital and undergoes groin access and goes to the lab, cath lab, but doesn't end up having a procedure. However, the patient thinks that they might have had the procedure. So this is the closest way to look at efficacy of renal denervation in the best way. And you can see even the sham patients had a 2 millimeter of mercury drop in their blood pressure. Now, in the ultrasound renal denervation group, they had about an 8 millimeter drop. And this was similar in patients taking one medications or patients that were on two medications and stopped both their medications. So this, on the left side, these are patients that stopped their medications. On the right side, you can see for resistant, this is the trio, Radiance trial, the trio, on 3 meds, about an 8 millimeter drop. So you can see there is statistical significance in benefiting their systolic daytime blood pressure. However, it's not a game changer. It's not like the study I showed you where Max Pete disrupted the renal splanchnic nerves. This is the equivalent of one tablet. That's what I tell my patients. I say it's the equivalent of, say, for example, amlodipine. You know, if you stop amlodipine, it's the same effect as a successful renal denervation. Now, in the pooled analysis of all the Radiance studies, you can see the average age is about 54, about 30% female sex, majority whites, but there was about 16% black. The patients' weight, they were all obese, about BMI 30 plus or minus 5, 10% diabetes, 16% sleep apnea, but generally patients that are free of cardiovascular disease. Their average number of medications were about 2 meds, and their average blood pressure was about 154, which again is not very high. 154 would be mild to moderate hypertension. Now you can see that the higher the patient's blood pressure to begin with, their daytime systolic, the better result, the better improvement they had in their systolic blood pressure. Compared to patients that had 140 blood pressure, they only had about 6 millimeter drop. Now, you must be wondering, what are the risks of undergoing renal denervation? So, there was one mortality in the renal denervation arm. However, it was not related to the procedure. It was a patient that passed within 30 days of a vascular event. In terms of requiring blood transfusions, there was no need for blood transfusion. One person had a vascular issue with groin access, but nobody had a stroke or MI or any issues with perforating a kidney or a renal artery. So it's a very safe procedure. Now, the other question that comes to mind is, how does renal denervation, how does it work in terms of longevity? Does it work after a few years? Yes, the answer is up to 3 years. We have studies looking at the improvement in blood pressure remains. Now, between 2 months and 6 months, patients' medications were restarted, and you can see they're still on medications at the 36-month mark. Now, if we look at the international guidelines, the ESC, the European Society of Hypertension, and Spanish and Italian and Netherlands guidelines include patients that be referred for renal artery denervation to include patients that are resistant. So all the societies agree that anyone that has true resistant hypertension should be considered to have consideration for renal artery denervation. They also include patients that are intolerant of drugs. Now, some patients just can't tolerate drugs due to side effects. And I have a case where I will show you a patient that wanted to get off of medications. So I will talk about that. Now, in a 2023 publication by Mancia et al. In the Journal of Hypertension, they had this 3-pillar approach where the first thing to do is obviously tell people to adjust their lifestyle, reduce salt, quit smoking, regular physical exercise, fruit and vegetable rich diet, and lower alcohol. Combined with medications, okay? Medications, if you have pill combination, it's better. Dual pill combination or triple pill, either an ACE, a calcium channel, and a diuretic. And to make it easier, because we know compliance is one of the main issues for patients with hypertension. And then lastly, renal denervation. Not for all patients, but I think for younger patients that are truly compliant with their medications can be considered. So back to case 1. This was my 50-year-old lady. This is her left and right kidneys. You can see the outline of her kidney. And this is a single. She had bilateral single arteries. Now, some patients have dual renal arteries, which is not uncommon. About 15% of patients have 2 arteries supplying their kidney, each kidney. So this patient was enrolled in the spiral study, which was the Medtronic study. And this is electrodes. These black dots are electrodes, heat electrodes, and they use thermal ablation to burn in 4 different points. And we do this in many locations in the kidney arteries to try to burn the nerves in the adventitia. Now, this patient had an improvement in her LVH. Her echo showed improvement in hypertrophy. She ended up being a super responder, which is not a common scenario, a super responder. Post-procedure, she was hypotensive, and I admitted her for groin monitoring and blood pressure monitoring. I stopped 2 of her antihypertensives on discharge. At home, she had pre-syncopal episodes, so she herself stopped all her medications, and her repeat ambulatory blood pressure ended up being 140. And we published this case, I think, last year in BMJ, and we presented her case last year in EuroPCR in Paris. So case number 2, this is a younger patient, again with essential hypertension diagnosed at 16, only on 2 medications. This patient had a negative secondary hypertension workup, had a prior alcohol ablation renal artery alcohol ablation 2013, had a Medtronic spiral catheter denervation 2022, and remained hypertensive. He tried multiple other medications, was intolerant. So he was able to be enrolled into the renal denervation study. He didn't want to take any more medications due to side effects, and he was enrolled into the ultrasound catheter, which is the ReCor Paradise catheter. This is his pre-op aortogram. You can see that he has single kidneys on each side, 1 kidney here and 1 kidney here, kidney artery. These are selective angiography of his kidneys. This was a case from over a year ago. We do measurements using QCA of how big his artery is on each side. And then we use a balloon that stabilizes this ultrasonic device. It releases ultrasound waves, which disrupts the nerves in the arteries. So this case lasted 55 minutes, and the patient was discharged home the same evening and had 2 sonications on the left and 3 sonications on the right. It's a very quick procedure. The ReCore catheter is much quicker than a Medtronic spiral catheter. Now, question might come to mind, who should be performing renal denervation? I think interventional cardiologists can be trained in performing this procedure. Interventional radiologists and vascular surgeons as well, trained in endovascular, I think can perform this procedure. In terms of what you need, you just need a cath lab. You need very meticulous intravenous sedation because it's very painful. While you do the sonications, the ablations can be, patients feel it, and some of them are screaming in pain on the table. So you have to give good amounts of sedation with fentanyl and midazolam. You need a femoral access. At the moment, they are working on a radial sheath, a radial device, but at the moment it's not on the market. You need a workhorse wire and you need the catheter. Now, last year we published this with a group from, so this was the whole group, and Dr. Goldberg, Sheldon Goldberg's my mentor from University of Pennsylvania. We published this review article on renal artery denervation, the management of hypertension, current trends and future direction. This is open access available, published in the American Journal of Medicine, which touches upon really the state-of-the-art contemporary management of hypertension using renal denervation. Now, this is my summary slide. The global burden disease of uncontrolled and resistant hypertension is not improving despite the awareness and despite the availability of medications. And the medications nowadays are actually very cheap, so there is really no excuse cost-wise for patients not to take their meds. 2025 renal denervation has been shown to be safe and effective in patients that are struggling to control their blood pressure with meds. I think it's really important to have shared decision-making with your patients and tell them about renal denervation, tell them about compliance, the risks and benefits and alternatives. And that's it. I'll take any questions from anybody. And thank you again to Professor Zaidi and Professor Quyyumi and Sakina Naqvi for the invitation.
Thank you very much, Ali. That was just superb and a fantastic review of the science and the results behind this procedure for treatment of hypertension. And I'd like to second what Ali just said, which is that these conferences are really here as a result of the work that Dr. Shabi Zaidi has done with SIVU and is sponsored by SIVU. I can start with questions, but I'd encourage any of the participants to do so. If you want to just put your questions in the chat, you're welcome to do that. You can raise your arm and we'll call upon you as well. But I'll start with one question, Ali, just to get it going. I was wondering whether there are now long-term follow-up results of what happens with this procedure. For example, are there downstream advantages, that is further reduction in blood pressure over time, perhaps because of the time it takes for all of these things to scar, etc. And also sort of end organ stuff, like does the renal function improve or not, those kinds of things.
Yeah. So to address your first question there, like I mentioned, there's 3-year follow-up on the ReCore, which is the ultrasound-based device, and the blood pressure control stays, the improvement stays after the procedure for up to 3 years. We don't have data more than that for the ReCore device. For the Medtronic device, we have similar data as well, where it does work. One thing I didn't mention, there is about 7 patients out of 10, which we term them responders, and 3 out of 10 patients don't respond to the procedure the way we want them to. And that's one thing I consent patients. I tell them there is 3 out of 10, 30% don't respond. And I think it's because the mechanism of their hypertension, the mechanism that's driving their hypertension, is not related to the renal artery nerves. And the second question about the kidney disease, there is one study that looked at renal denervation and the progression of EGFR. And in patients with mild CKD, EGFR above 45, the progression of kidney disease is slower in patients that undergo renal denervation, probably from the hypertensive, antihypertensive effect.
Got it.
I think Ajaz Haider, the question.
Yeah, thank you. Yeah, thanks, Dr. Ali, first of all, for the excellent presentation. Fascinating technique and a lot of takeaway points for hypertension. So I'm a general practitioner, so sometimes I see patients who've been walking around with high blood pressures for an unknown time, asymptomatically before diagnosis. And when I treat them and bring the blood pressure down to normal levels, they just feel unwell. They feel dizzy, they can't concentrate, they feel weak. And in renal denervation, obviously, it's a very sudden and very extreme drop. So, first question, have you experienced that in your patients? And a second different question with the young patients that you have, is there any common genetic mutation reason for their high blood pressure at young age? Thanks.
Okay, thank you for the question. So to address your first question, yes, so the first case I showed you, the lady who was 52, when I controlled her blood pressure with medications and then brought her for renal denervation, she told me that she felt completely exhausted and had no energy to even get up out of bed and walk. And this is because most patients get very used to having a blood pressure of 200, and they have more energy because the brain has more pressure in it. So yes, patients get exhausted after you control their blood pressure. The other thing is, I would advise you to check a 24-hour blood pressure in patients that feel exhausted. And the reason is because sometimes they have white coat hypertension. They don't check their blood pressure at home. And instead of being 140 at home, they're running at 85, 90 at home, in which case you need to cut back on their medication. So there is a subset that feel tired, but when they come to the office, it's 140. But when they go home, it's running at 90. So that's one point. The second question you had was, what was the second question?
Young patients, these young patients.
Genetic, yes. I
genetic,
don't actually know. Maybe Professor Quyyumi can comment on genetic polymorphisms. I don't think we have identified specific genes, at least a gene panel that we can run to say, yes, you will be prone to having hypertension. But in my experiences, most patients that have hypertension diagnosed at young ages, they have a family history. Yeah.
As you know, hypertension is a polygenic disorder. It's very rare to find a sort of familial polymorphism or mutation that runs in families, although there are obviously exceptions to this. I'm saying rare. So the advice isn't to go genotyping people who at a young age with hypertension. I mean, I work in the US, and the African American population develops hypertension in their 20s. And even their teenage years, you can see their blood pressure at the upper limit of normal. You can actually predict who's going to become hypertensive, et cetera, et cetera. So this condition can occur very early in life, and it doesn't necessarily mean that you have to go look for your rare disorders, particularly in certain ethnic racial subsets. But it is a complex field. I think what we're emphasizing here or realizing here is, even though we call this essential hypertension, it's a series of different conditions. We have no idea what the pathophysiology is in an individual, but all we have is this measurement of blood pressure that we treat with this blunderbuss approach of a calcium channel blocker and ACE, ARB, like you listed. And even while you're doing that, you will realize that different people are responding very differently in terms of reduction in blood pressure to these additional medications that we keep adding. Sometimes there's a dramatic effect with, say, adding a calcium channel blocker. And then we have these vague sort of guidelines about, you're African American, you should get more thiazide first and calcium channel blocker next. And that's because we really don't have a tool or tools to really know what each individual's hypertension is driven by. And the same applies to this technique, for example. What's the selection process to find that excellent responder that Ali showed, with a normalization of blood pressure and coming off all the medicines, which was driven by the renal arterial input. Whereas there are lots of people who have a 5 millimeter drop, and you say, well, that's like a one pill. Why go through all of this? Yet we have no ways of selecting the right individual. And that's going to be the challenge. And this is going to probably happen when this procedure becomes much more prevalent and you have registries and start to study people at a biochemical level to see, what the selection criteria should be. So I think we're early in this technology. The fact that we have devices of various kinds that help is very exciting for a condition that really is the most common risk factor on earth that causes cardiovascular disease, stroke, etc. So it's an exciting time. And it needs really skilled people to do this procedure. And we have some other questions, by the way. Let me see if I can read these out. There's a question about have there been studies in people with renal artery stenosis that have undergone dual procedure of revascularization and renal denervation, and what are their outcomes?
Yeah, so that's a good question. So one of the exclusion criteria for all the patients that enter, one is to rule out secondary causes of hypertension, and amongst those, renal artery stenosis is listed as a contraindication. So they get excluded. So at least the patients entering all these registries, the Medtronic study and the RECORE study, we don't do this procedure in patients with renal artery stenosis. And one of the risk factors, one of the complications of the procedure of heat ablation is in fact causing stenosis, and usually it's not severe. It's usually 20% residual stenosis from the ablations. So it can make things worse. Another question is thinking about renal nerves hyperstimulation as a cause of intractable hypertension is only made when patients had these high readings, or are there any lab markers available, such as renin levels, ACE levels, or neurometabolites? So I think we still don't know, like Professor Quyyumi mentioned, we don't know who has hyperstimulated renal nerves. The first case I showed you definitely had it because of her response to the procedure. But in all comers, like I said, super responder, maybe 1 out of 50 cases will respond as a super responder. The majority have an average of between 5 to 10, somewhere in that range, improvement of systolic blood pressure. And the labs that you mentioned, they are routinely part of the endocrine workup of secondary hypertension. So we would check urine metanephrines, we would check renin levels, aldosterone levels. So this is commonly done to rule out secondary causes of hypertension. So there's another question by Mona. In long-standing cases of hypertension, vascular remodeling usually occurs. Is it possible to regress after successful renal denervation procedure? So what we have noticed, particularly in the Medtronic study, there is a process of regrowth of nerves. So if you don't ablate all the nerves, so the Medtronic catheter has 4 ablation points. If you don't ablate them fully, they regrow, and they last the effectiveness of the denervation is about 6 months to a year. With the RECORE study, because it's circumferential ablation, the studies show that most of the nerves get burnt away and they don't regrow. In terms of long-standing cases of vascular remodeling, yes, they do reverse. LVH does go away. It is reversible. And so, yes, the quicker you control your blood pressure, the better it is. And then question from Dr. Hussain, what's the way of identifying the minute minute nerve endings while you are in the renal artery? Is there an immediate way to get confirmation that the procedure is successful within the cath lab? That's a good question. The Anecdotally, the patients that have very severe pain when you're ablating is the way that I know that they're having really good ablation. If they have less pain and require less fentanyl, anecdotally, my experience is the patients that have more pain are having better ablation and better nerve disruption. So that's my immediate way, but there is no lab test apart from doing the ambulatory blood pressure monitor after they get discharged. That's the only way to know if it's a successful ablation.
Thank you, Ali. We are almost at the end of the hour, but just had one more question. Are there any exclusions to this procedure? Like, should we not be considering this in certain people with hypertension?
Yeah, I think anybody who has secondary hypertension should be excluded. Anyone that has renal artery stenosis, either unilateral or bilateral, any patient whose artery is smaller than 6 millimeters, okay, should be, 3.5 millimeters. You cannot ablate any artery smaller than 3.5 millimeters. So some patients have multiple renal arteries on both sides and not just one single one. So if they have multiple smaller ones that are small in size, you can't fit the device inside their artery.
What about renal function?
It has not been done in patients with end-stage renal disease, but patients with eGFR above 45, it's allowed to be entered into the studies, both Global Paradise as well as RECORE, and the Spiral study. Both studies allow an eGFR above 45. But anything worse, we have not been including into the registry. They can get it done privately with an eGFR above 30, but we don't recommend it below an eGFR of 30. So stage 3.
And the reason for that is that because you're using contrast, or is that can it be done with ultrasound? Is that the reason? Or
no, you could do it with very minimal contrast or even no contrast with ultrasound. But I think in end-stage renal disease, the kidneys obviously atrophy and they reduce in size. So we think that the effect of the kidneys contributing to the blood pressure is less so caused by the nerves and more so caused by lack of urination. And in the patients with stage 4, it's the main reason that we recommend not to do it is for the contrast risk. You're right. Yeah.
Are you doing this work in Iraq also, or is it confined to US?
There is currently no place in Iraq doing renal denervation, and it's unfortunate. The companies, they are not very excited to come to Iraq, unfortunately. In Kurdistan, maybe it will be done in the next year, but at least in mainland Iraq, Baghdad, Karbala, Najaf, nobody's doing it. Mainly due to lack of availability of the equipment.
Also, I think there's a problem of medical indemnity and professional protection. I think that's a major issue there.
For example, the Medtronic TAVI valve you can't find in Iraq because of
No, we tried it many times in the past, spoke to medical insurance here in UK, Medical Protection Society, even to the Lloyds, the major firm. They're not interested in Iraq because they say it's a very tribal culture. It's very difficult to indemnify. If you have any fault, then you know what happens.
It's not covered by the insurance. Right?
No, it isn't.
We have additional questions in the chat, please.
Yes. How much does the procedure cost? It costs about $10,000 in the UK. I think in the US, I think it's closer to 15, and sometimes some places I've read $20,000 is the cost of the procedure in the US, and that's how much the insurance are getting billed. But I don't think the catheter costs that much. I think that's just how much the US hospitals are billing for it.
Why do you say it costs in UK? Is it available only privately?
The UK, the only way to really do it in the UK, because it's the NHS, is as part of the RECOR registry or the Medtronic Paradise Global Registry, because the catheter comes for free. You just the hospitals just have to pay for the cath lab time, physician time, and the medications. Even the catheters the hospital has to take out of their own costs. So the company pay for the ablation device only, and that's the cost to the UK for the catheter.
So, do the people have access to the global registry if they are in a country that does not do this procedure? Can
No,
they? No?
no, unfortunately not. Only there's centers in Europe, Germany, France, Italy, UK, and US. I think these are the main countries that are putting patients into the registry. Apart from those countries, if you want this procedure done, you can't have it, unfortunately.
There's
As part of
another
the registry.
question. Thank you. There's another question. Why is it allowed privately? Um,
I think as long as the company gets payment for their catheter, they're happy for the physician to screen the patient and allow the patient to have it done. For example, in Saudi Arabia, you can get renal denervation in Riyadh and in Jeddah, and it's done privately where the patients are paying for the procedure. And then again, those patients are not enrolled into the global registry. They are done outside of the registry. Any other questions? Since the renal nerves can regrow, is the denervation repeated? I think that the goal is to get all the nerves on the first go, but we do have patients, particularly with the Medtronic catheter, where they need a repeat ablation a year later, and I've seen that done before. For RECOR, I have not had a single patient, because it's circumferential ablation, I have not had any patient come back for a second procedure.
All right. Excellent. Thank you very much. We've gone over time because the talk has been truly informative. Great questions. I would like to start off by thanking SIVU for organizing the conference and Dr. Zaidi and his efforts over the years to make these on a recurrent basis. And of course, to Dr. Ali Naqvi for this scintillating presentation. We hope to hear more from you in the future, and for all of you attending. Just in the chat, there is a link for you to receive the certificate. If you could just register that. We will also be sending out to you this newsletter on hypertension management that will have the link to this presentation, so you can share that with your colleagues. The pamphlet, the newsletter, is actually meant more for public use as well, so you can use that for your patients as well in terms of understanding hypertension. So thank you very much, and we will end it here.
Thank you.
Aaron, do you have anything else to add?
no, that's about it. The only thing is that if you need a certificate, please enter your name and your email in the link. Otherwise, we will not be able to provide you with one. Thank you so much.